Thank you for joining us for this webinar. My name is Dr. Karamanian, and I'm a board-certified diagnostic radiologist, an interventional radiologist, a biomedical engineer, as well as the medical director of the Prostate Laser Center. This talk is entitled Diagnostic Prostate MRI and MRI Guided Focal Laser Ablation for Prostate Cancer, Preserving Quality of Life. I am the owner of the Prostate Laser Center, otherwise I have no disclosures. So how do we screen for prostate cancer? Traditionally, this involves a digital rectal exam, as well as a PSA blood test. This test has a reputation of being sensitive but not specific. I would argue even its sensitivity is not that great. Using a cutoff of 4.0, it only has a 51% sensitivity for high-risk prostate cancer. Using a cutoff of 3.0, which few people do, it still only has a sensitivity of 68% for high-risk prostate cancer. Alright, so we screen the man. His PSA is positive, or he has a positive digital rectal exam, or both. What's the next step? The next step is to do a transrectal ultrasound biopsy, also known as a truss biopsy. Alright, well, what is a truss biopsy? On this truss biopsy, we can see a transrectal ultrasound device inserted through the rectum. A needle is then slid past it into the prostate without really seeing a target. What ultrasound allows us to do is see the outline of the prostate and the different sections of the prostate anatomically, but we don't really see a target that we're trying to biopsy specifically. So how does one divide up the prostate into different segments? Well, you take the top third, which is the base, the middle third, which is the midgland, and then the bottom third, which is the apex. Then the prostate is divided into right sides and left sides, and then each side is divided further in half with the medial aspect as well as the lateral aspect. This results in 12 segments. A biopsied needle is advanced into each one of those 12 segments, hoping to hit a clinically significant prostate cancer. But again, because there's no target, it's considered blind. Well, this has implications in terms of sensitivity, where there's only about a 75% sensitivity for clinically significant prostate cancer with a truss biopsy. And because the biopsy is performed 12 times in different areas, that's a lot of punctures. This then results in a relatively high risk of infection, with about 1% of patients ending up in the hospital with urosepsis. Some of the issues with a truss biopsy is that there is a significant risk of infection, which increases with the number of samples taken. There's also a relatively small risk of erectile dysfunction. It may be of unclear cause. I suspect that it may have to do with the needle being passed right next to the neurovascular bundle. Also, there's only a mediocre sensitivity for clinically significant prostate cancers, as well as too high of a sensitivity for clinically insignificant prostate cancers, which can result in overtreatment. Here we see an example of a segmental or truss biopsy that, despite the 12 samples, completely misses this tumor right there due to sampling error. There are several outcomes of a truss biopsy which are suboptimal. One is the needle can completely miss the cancer. It may miss the significant cancer while hitting an indolent cancer, which then leads to a false sense of security. It can also hit the less aggressive portion of a tumor while missing the more aggressive portion of the tumor, as we see in this example. A urologist at the Mayo Clinic put it this way: the problem really begs the question of whether we could do better with prostate cancer diagnostics. Despite local anesthetics, the whole procedure is barbaric, and it is surprising that the issue of infection has not come to light years ago. Well, maybe we can do better. A multiparametric prostate MRI before a truss biopsy is a good option for many patients. It does have a better negative predictive value than a truss biopsy for clinically significant prostate cancer. In other words, a patient with a negative multiparametric MRI performed well can have more confidence that they do not have a clinically significant prostate cancer than a patient with a negative truss biopsy. Some patients will still undergo a truss biopsy following MRI to have an even higher degree of certainty. That's especially important for high-risk patients. Well, why isn't a multiparametric prostate MRI routinely ordered before a truss biopsy? One reason is practice patterns. It's not the standard of care. Some insurance companies won't pay for it, although Medicare will, and nobody wants to spend even more time on the phone with insurance companies fighting with them. There's limited access to high-quality prostate imaging, which has improved tremendously over the last several years. There may be financial bias with some practitioners because if a patient undergoes a multiparametric MRI, it turns out to be negative, they may then decide that they don't want a trust biopsy. What if the trust biopsy is positive? Do you need a multiparametric MRI afterwards? The American Cancer Society in March of 2016 said, MRI scans aren't usually needed for newly diagnosed prostate cancers that are likely to be confined to the prostate based on other factors. Now, they're the American Cancer Society. I'm just one lowly physician, but I disagree. Multiparametric prostate MRI after a trust biopsy has several benefits. It will often find a focus of cancer, which is more concerning than that which was diagnosed on a trust biopsy. Roughly 50% of Gleason 6 tumors diagnosed on trust are upgraded following a radical prostatectomy. That means that many of these patients who at the time would be considered good candidates for active surveillance may not actually be good candidates for active surveillance, and MRI will significantly help to risk stratify patients in terms of being good candidates for active surveillance, or if they see a lesion on the MRI that's more worrisome, that does not correspond with what the pathology findings were, then a needle can be placed using a targeted biopsy of that other lesion in order to determine if they really are a low-risk patient or not. Furthermore, it can help stage cancer, which can be important for treatment planning. Patients will oftentimes get a CT scan, which offers minimal benefit. A prostate MRI has tremendous sensitivity for extracapsular extension, especially when compared to a CT scan, and that has real implications for treatment planning. Now, the disadvantage of doing the MRI after the trust biopsy is that one must wait 8 weeks after the biopsy, and the reason for this is that the biopsy causes hemorrhage changes in the prostate, which can cause significant distortion and artifact. You may have heard of a 3T MRI and a 1.5T MRI. Well, what's the difference? In prostate imaging, there's actually a really significant difference in that a 3T MRI, which has twice the magnetic strength of 1.5T MRI, has a lot more signal that it can extract from the patient, which means, practically, that a 3T MRI without an endorectal coil gives roughly equivalent image quality as a 1.5T MRI with an endorectal coil. And you can imagine which is going to be more comfortable for a patient. There are some caveats. The multiparametric prostate MRI must be performed well. A 3T MRI or a 1.5T MRI with an endorectal coil. The radiologist should be experienced in reading prostates. And one must wait 8 weeks after a trust biopsy. Now, a trust biopsy can also pick up some clinically significant cancers that MRI missed. So it's important not to use the MRI to exclude all patients from a trust biopsy, especially those patients who are high risk. Moving on to treatment, once the diagnosis is made, there are the traditional whole gland therapies such as radical prostatectomy, radiation, proton therapy, focal options such as laser, HIFU can be focal or whole gland, same with cryo, or no treatment, active surveillance or watchful waiting. With radical prostatectomy, there are serious side effects, and it is major surgery even when using a Da Vinci robot. Unfortunately, it turns out that the robotic approach hasn't really decreased the rate of side effects, but it has decreased the amount of blood loss, and it allows patients to get back on their feet faster. But the overall risk of side effects is equivalent whether one uses a Da Vinci or not. At least that's what the literature shows. There are significant risks of erectile dysfunction or impotence. That's about 50%. Urinary incontinence is about 25%. It requires general anesthesia, significant recovery time, and most men lose about a centimeter after the surgery. Radiation therapy has significant risks of erectile dysfunction or impotence, radiation proctitis, radiation cystitis, fatigue. There is a minor risk of urethral stricture. And radiation therapy also makes surgery in recurrent cases much higher risk and technically challenging. And also let me make a comment on proton. Proton therapy for the prostate has shown a roughly equivalent risk of side effects as radiation therapy. So unfortunately, that has not shown itself to be the advancement that we were hoping it would be. Now, all these treatments have been shown to save lives, but they still require lifelong surveillance. And what that tells to me is that none of these treatment options can be considered a cure. We still need to follow up. We still need to keep an eye on our patients. And unfortunately, a lot of patients end up with serious side effects after these treatments. With all of those risks, many of which occur frequently, maybe the patient should just take his chances without treatment. Thus, active surveillance was born. And it is a reasonable option for patients with very low risk or low risk prostate cancer. But for patients expected to live more than 10 years, who have intermediate or high risk disease, it's not recommended. MRI guided focal laser ablation, I believe, fulfills a need between whole gland therapies, which tend to be very traumatic, and active surveillance, which means no actual treatment of the cancer. This option is minimally invasive. It's an outpatient procedure, no general anesthesia. Patients have a rapid recovery. There's a low risk of side effects. It is repeatable if necessary, if residual disease is left, or if down the line a patient develops a new focus of cancer somewhere else in their prostate. And it does not limit whole gland therapy should it become necessary. It's not like radiation. Should a patient need surgery at some point down the line, it doesn't make the surgery any more technically challenging. The disadvantages include that while we do have good short-term disease-free survival data when it's performed by a skilled practitioner, we don't have long-term data demonstrating improved overall survival. The technology hasn't been out long enough for that data to be collected. Furthermore, there is a high out-of-pocket expense because insurance and Medicare do not cover it. Currently, practitioners charge in the range of $20,000 to $32,000 for this treatment. High-intensity focused ultrasound, or HIFU, is another emerging technology. This has limited quality long-term data. It's not nearly as precise as laser, which means it does have a higher risk of side effects compared to laser. The vast majority of HIFU practitioners use ultrasound guidance, not MRI, which means that they cannot obtain real-time temperature measurements of the tissue that they're ablating. They can't really evaluate for adequacy of the ablation like an MRI can. A Foley catheter does need to stay in for about 2 weeks after the procedure, although there are some practitioners who insist that every patient undergo a TURP prior to HIFU. Those patients don't need a Foley after the HIFU treatment. Insurance and Medicare also do not cover it, similar to focal laser ablation. And the HIFU in the vast majority of cases is performed by a urologist, as opposed to somebody like me who's an interventional radiologist. There's also cryotherapy or cryoablation. This technology is not nearly as precise as laser. It's much more invasive than laser is. It can be a good option for patients with bulky disease because it can treat larger tumors, or for small central tumors which are far away from the neurovascular bundle. It requires general anesthesia as well as a hospital stay in most cases, and insurance and Medicare do cover it. It has been around longer. Here's an example of tissue that was taken out following a focal laser ablation as well as following high-intensity focused ultrasound. Here we can see that the zone of transition between ablated tissue and unaffected tissue is actually quite narrow with laser. This distance is actually 1 millimeter. With HIFU, you can see this zone of transition to be much, much wider. And if we make the scale the same on both slides, you get a sense of why I believe that HIFU is far less precise in terms of an ablation energy in the prostate as laser is. Here we have a pathology slide at 100 times magnification, and we can see that there's a very tight transition between the area of complete ablation and area of unaffected cells. Here's an example of an ablation that I performed, and here you can see the power of the MRI. Before MRI, the prostate was a black box. You couldn't really see into it. So if a patient had cancer, you'd take out the whole thing. But now that you can see where the cancer is, you can see the edges of it, you can see its characteristics, localization of the cancer using MRI enables focal treatment. Here's a axial T2 image. You can see where the cancer is. It's very clear. Here's the capsule of the prostate. And just above the laser pointer is the nerve responsible for erections. Here's an ablation map that was obtained during the procedure. The nerve is, again, just above the laser pointer. And 6 months after the ablation, on follow-up MRI, we can see that there's no evidence of residual tumor here. And there the nerve is intact. Although we don't have 10, 15-year outcome data showing improved overall survival from focal laser ablation, as a radiologist, when I see a cancer, I treat it, and then I don't see it anymore. That to me is pretty powerful. So how's this done? A patient is laid prone on the MRI table. A needle guide about the diameter of my index finger is inserted after the patient is sedated. And then through that needle guide, there's a little opening which allows passage of a cooling cannula, which is 1.85 millimeters in diameter. Inside the cooling cannula, a laser fiber optic is placed, which allows the administration of the laser energy. Now, in contrast to HIFU, where HIFU, the vast majority of practitioners are using ultrasound or fusion guidance, MRI in bore guidance has many important advantages. It allows precise real-time targeting of the lesion itself. You can see the lesion. It's amazing. It allows you to measure temperature changes in the prostate as you're turning on the laser fiber, which then allows much better control of the laser energy, adjustments of the laser energy, and the location of the laser, which then allows much more precise application of that heat. You can make a much more precise zone of ablation using MRI guidance than without it. In addition, it allows one to monitor vital adjacent structures such as the neurovascular bundle, urethra, rectum, and bladder, which further increase safety. And then when the ablation is over, we do a post-contrast MRI. And what that allows us to see is the zone of ablation that we actually created, not the one that's based off of temperature maps or our experience. We actually see, did we kill the area of tissue that we thought we killed? That real-time feedback is tremendously helpful. Here's the temperature map from an ablation that I performed. You can see the real-time temperature changes in the tissue as the ablation is being performed, the increase in temperature of that tissue. And here's an ablation zone that's being created, and you can see how we're able to match up the edge of the ablation zone with the edge of the capsule precisely without hitting the nerve, which is right here, just a couple millimeters away. Furthermore, you can see this white fluid around the neurovascular bundle, which I inject for a couple reasons. One is it's dilute lidocaine, so it does provide analgesia. Also, it allows one to see the neurovascular bundle better, to visualize it better with the MRI, but also the fluid itself provides a little bit of a thermal barrier to help protect the nerve from the effects of the laser heat. Here's another lesion that I ablated. You can see the bladder is right under here, and we're able to successfully ablate a tumor in this part of the prostate without damaging the bladder. In the last slide, I showed an example of an ablation of a lesion that was right next to the bladder and how we're able to ablate that lesion without damaging the bladder. Well, how do you destroy a lesion that's right next to the urethra without destroying the urethra? Well, we put in a Foley catheter in the urethra, and through that catheter, we can use saline that we pump through the catheter as we're doing the ablation in order to ablate tissue that goes right up to the urethra without destroying the urethra itself. Here you can see this zone of ablation with a defect right where the Foley catheter is going through the urethra with cooled urethral saline protection. Now, let me give an example of such a case with a tumor that's wrapping around the urethra. Here you can see the tumor here, and the urethra is right here. Now, how do you destroy a lesion that goes all the way around like that without taking out the urethra itself? I thought about another case that I had performed for a cryoablation of a renal cell cancer. This was a challenging case. It was an upper pole lesion right under the lungs. We had to tilt the CT gantry about 20 degrees, use 4 probes, but we were able to get overlapping ablation zones to cover the entire cancer without damaging anything else in the process. And I applied that same interventional radiology technique to this prostate cancer. So here you can see I did one ablation lateral to the urethra, lateral to the cancer, one right next to the urethra on this side, and one right next to the urethra on the other side. And what were our results? Well, here we can see a zone of ablation that's wrapping around the urethra, and the patient did great afterwards. On their 6-month follow-up MRI, no evidence of residual disease. So how accurate is MRI thermometry? Well, there was an interesting study where patients were scheduled for radical prostatectomy. They were already going to have the surgery, and they were recruited for a preoperative focal laser ablation. And this is what the study demonstrated. Ablated areas were characterized by homogeneous coagulation necrosis. The MRI calculated ablated volume correlated well with histopathology. We found that FLA creates confluent ablation, with no evidence of viable cells in targeted regions. Post-ablation MRI is able to determine the ablation accurately. So what are the criticisms of MRI guided focal laser ablation? Well, one of the main ones is that prostate cancer is multifocal and you're only treating 1 or 2 foci. Well, this is true, but when you look at metastatic disease in patients, there was a very elegant study that sampled multiple sites of metastases in patients, and it demonstrated that all of the metastatic foci had one common cell origin. They used DNA to determine this. And so it's not that different foci contribute to varying amounts of their metastatic disease. These patients, all of their metastatic foci was from one focus in the prostate. Well, how do you know that if you're treating the right focus? Well, there was another study that looked at multifocality on pathology samples of whole gland prostates. And what they determined was that multifocality is a common feature on radical prostatectomy specimens, but is not associated with pathological features of poor outcome. Tumor volume, Gleason grade, extracapsular extension, and seminal vesicle invasion are almost invariably determined by the index lesion. And what we're doing here with MRI guided focal laser ablation is treating the index lesion or lesions. Another criticism of MRI guided focal laser ablation is that it is an experimental treatment because there's no long-term data showing improved overall survival compared to no treatment. It is true that this data does not exist yet. But then again, the first randomized study showing improved survival with radical prostatectomy over no treatment was not published until 2005. Does that mean that radical prostatectomy was an experimental treatment until 2005? Remember, there have been a tremendous number of radical prostatectomies performed before this data came out. HIFU also has no long-term data showing improved overall survival compared to no treatment. Yet some of the same urologists who call FLA experimental support or perform HIFU. Food for thought. The ideal prostate cancer treatment is going to be safe, effective, minimally invasive, and have a low risk of side effects. To date, we don't have any treatment that has proven itself to be optimal in all 4 of these areas. And so it really does come down to a patient treatment decision. Hopefully one day we'll get there, but we're not there yet. No single treatment option is best for every patient. Multiparametric MRI offers a true breakthrough in prostate cancer imaging, which opens the door for targeted diagnosis and focal treatment. And for those patients who are good candidates, MRI guided focal laser ablation can be a compelling option. Thank you for your attention.